Hey everyone, my name is Carly Michaelina, and today I'm going to be discussing with you guys the pathophysiology and the diagnostic criteria associated with asthma. First thing first, I do have a couple PowerPoint slides that I'm going to try to follow along with you guys for visual learners. But pathophysiology for asthma, it is kind of the exact cause is kind of unknown, but there are some factors that are key and play a major role as far as increasing the chances of getting asthma or an exacerbation of asthma. Some of those things are environmental allergens such as mold, dust, pollution, animal hair, those types of things, smoke. And then there's other indicators that I've got listed at the bottom, like exercise, temperature extremes, illness, and anxiety. And as we know, anxiety, illness, temperature control, we tend to vasoconstrict. So that can definitely increase people with asthma, their chances of having that vasoconstriction and that bronchospasm. Another thing that we want to talk about is the inflammatory and the immune response as far as chemical mediators. The first thing that typically gets initiated is something called the IgE, mediated hypersensitivity reaction. And this is stimulated as soon as we have exposure to that trigger, which are those mold, animal hairs, pollution, those types of things. After this, mast cells release further chemical mediators such as histamine, prostaglandins, also leukotrienes, which are basically indicators of that allergy. So it's extra chemical mediators that are released after we get exposed to that allergen. Further, this can cause bronchospasm, it can cause swelling, excessive mucus production in the airways, which in end makes it harder for us to breathe, and more of that bronchoconstriction and that spasm of the airways. This can later cause permanent chronic inflammation. It can go along with eosinophils, which is basically a lab that we have that indicates exposure to an allergy. Infiltration of the airways that cause destruction of our respiratory epithelium. Smooth muscle hyperplasia, as well as narrowing of the airways. When these things take place, it's something due to called airway remodeling. And in airway remodeling, these are permanent, most of the time, permanent things that are happening after we become exposed to an allergen but so many times, which can in turn become irreversible. Next slide I want to show you is just a picture of a clinical model of asthma. Up here it talks about the allergen exposure, and then it develops lower to show you kind of the steps of what happens, which is basically what I just talked about. And then also the unobstructed airway and the obstructed airway. So you can definitely see the big difference in those two, how open this one is and how constricted this one is. Next thing that we're going to talk about is the diagnostic criteria associated with asthma. Some big diagnostic criteria that we want to focus on is when our patient comes to the hospital or a primary care facility, anything like that, we want to make sure we look at if they have evidence of respiratory distress. And sometimes these clinical manifestations might not occur right on scene. It might be something they previously experienced. They've been exposed and they just came to the doctor's office, that kind of thing. We want to look for wheezing sounds. We want to look for a prolonged expiratory phase. So if they're breathing in and then have a long expiratory phase. Something called pulsus paradoxus, which is an exaggerated decrease in that systolic blood pressure. That is during inspiration. We want to look for atopic dermatitis, eczema, any type of skin condition that can show us or indicate hypersensitivities. Lab results, we want to look for eosinophilia, which is basically indicating an allergy, that our body is seeing an allergy and reacting to an allergy. Arterial blood gases, which are super indicative of hypoxemia as well as hypercapnia. So when we do that cap refill, are we getting blood return and oxygenation less than 3 seconds or more than 3 seconds? Spirometry is used to determine the effectiveness of our airflow. We use the peak expiratory flow rate, which is PEFR. This is common for tracking forced expiration. So if we're forcing ourselves to expirate rather than it just being a natural inhalation and exhalation. The peak flow meter is super easy. All the patient really needs is education and how to use it, why we use it, especially those incentive spirometers that we leave in those patients' rooms. Over time, it may be a chest radiograph that the patient is receiving as far as diagnostic criteria, because we want to make sure that this is asthma and it has not led to further infiltration of the lung or hyperinflation, which leads to that collapsed lung, which is a pneumothorax, or pneumonia, as well as a collapsed lung or a pneumothorax, which is the presence of air in those pleural spaces that can cause a lung to collapse. Once we diagnose this, it's super quick return needs to be with that treatment plan, because the further or the sooner we do that treatment plan, the more likely those patients have a lesser chance of getting that pneumonia and those more exacerbated signs and symptoms that just started with asthma or just started with something. So these diagnostic criteria are huge. When a patient presents, we definitely want to look at their family history, their past medical history, to make sure that we're getting all the information and the resources that we need. This is all that I have for you on pathophysiology and diagnostic criteria, and I hope you guys enjoyed.